go to the next topic, which is a debate. So do we have both
So
these
I
speakers?
think the debate is not there now,
Yeah.
and Dr. Tripathi will be talking on rate versus rhythm control.
Yeah, excellent. So
right?
may I invite
Yeah.
Dr. Nityanand Tripathi, a very close friend who we worked together for long, many years. So he'll be speaking on rate versus rhythm control. So it's been ongoing topic for many, many years since the, I think, atrial fibrillation started. So let's hear him out. What are the advantages of rate control and what are the advantages of rhythm control? And especially in the current era where we have got a lot of curative treatment like pulse field ablation, cryoablation for atrial fibrillation, and more and more. So there are certain centers across the globe who are doing only atrial fibrillation. The AVNRTs and AVRTs have all been ablated. So only AF has remained there to be ablated. So over to Dr. Tripathi.
Thank you, sir. Thanks for a nice introduction, in fact. And I will thank Dr. Rakesh Gupta for inviting me here. In fact, I prepared to speak about the rhythm control, why rhythm control is important and why rhythm control is better than the rate control. But somehow, since my opponent is not there, so I will be a little balanced.
Over. So go ahead.
So, for decades, the management of atrial fibrillation has been dictated by the central tenet of the clinical equipoise, a doctrine suggesting that controlling ventricular rate is a goal non-inferior to the ambiguous restoration of the sinus rhythm. And this is based on the trials which were published in the initial era, like late 90s and early 2000. The main 4 trials on which this tenet is based is on AFORM, RACE, PIF, and STIF. 2 of them of European, and one is from US and another from Canada. These studies concluded that rhythm control strategies show no significant benefit for hard point like mortality or stroke over a simpler rate control strategy. Rhythm control often came with a baggage of increased hospitalization and drug side effect in these trials. Mind you, these trials are 20 years earlier. The trial PEP has a primary finding that no difference in the symptom improvement or exercise tolerance was there between these two groups. However, it has a small sample size to detect any difference, and follow-up was must just for 1 year only. The staff came in 2000, and the primary finding it showed was a trend towards the worsening of the outcome, like stroke and death in the rhythm control arm. And it was prematurely stopped in favor of rate control, and there was a high warfarin discontinuation, and the drugs were ineffective and older one. So since there was a high warfarin discontinuation, that is why the stroke rate were high. The race came in 2002. It found no difference in composite CV endpoints like deaths, heart failure, stroke, or bleeding, but there was a high crossover rate. The late intervention was there in patients with the structural heart disease, which were destined to fail for the rhythm control. We know that as rate is allowed to, or AF is allowed to persist, there is a fibrosis and irreversible changes. Therefore, rate control is better than the rhythm control, and rhythm control is bound to fail here. Final blow for the rhythm control came with the AFORM trial in 2002, published in the NEJM, which showed no difference in all-cause mortality, more hospitalization in rhythm control. But here, the interventions were late for the rhythm, and AF was more than 3 years. That means already the structural changes had set in here. So these trials were not testing the early rhythm control strategy. In fact, testing a late pharmacologically limited rhythm control strategy in patients with the already established remodeled atrial substrate. And the null finding was preordained by the study design itself. So coming to the newer methodologies and newer data, the AFib is a progressive disease of adverse substrate remodeling. We know it that AFib begets AFib, and it has been proven by a number of trials and by number of investigators. Stanley and dozen of other investigations have shown that progression from electrical to structural remodeling, if we allow AF to persist for a longer period of time, and there will be a fibrosis in the atrium. Technologically, the rhythm control arm in a form relied only on quinidine and sotalol, shown to be poor in controlling the rhythm, and they rather control the rate only. Today, our primary tool is pulmonary vein isolation by cryoablation or contact force sensing radiofrequency ablation and PAF, that is coming fast in our clinical practice. And these are the tools who were not present in 20 years back, and they have more than 80% efficacy for maintaining sinus rhythm in paroxysmal atrial fibrillation. The result unimaginable that time when we base our theory that the rhythm rate control is the better one. The appropriate endpoint was not there. It is not good to base our only rely solely on the blunt endpoint of all cause mortality. It's not only one endpoint on which we should measure any like technological outcome. Modern trials use the more sensitive composite endpoints like CV death, stroke, heart failure, hospitalization that better capture the total burden of cardiovascular mortality rather than morbidity rather than the cardiovascular mortality, the all-cause mortality only. The INST AF Net 4, Castle AF, and other trials and myriads of the meta-analysis have shown that this rhythm control is far better when it comes in the terms of the clinical outcome or patient's outcome, and is significantly better compared to the rate control. If we talk about the AF Net 4 trial published in the NEJM, if we deep dive in the data, it shows that 21% relative risk reduction in the primary composite endpoint, translating into the number to treat is just 63 over 5 years to prevent one major adverse cardiovascular event. This is very significant number. It's a very few patients, that 63 only to be treated to prevent the one cardiovascular effect. The benefit was consistent across the pre-specified subgroup and driven by the reduction in the cardiovascular death to the tune of 28% and stroke to the tune of 35% in the patients who were controlled, in whom rhythm was controlled. The safety profile was excellent, debunking the old fear of the harm that was proposed by the older trials. The superiority was proven in the patients who are high risk. In early AF trial, 303 patients with untreated paroxysmal AF first line cryoablation was done, and it was compared to the anti-arrhythmic drugs. There was a whooping like 42.9% was reduction in ablation compared to the 67.8% event in the drug group, and significant or more than half reduction in the adverse events were there. The staff air trial published in NEJM recently in 2021, a similar cryoablation versus the first line therapy was compared, and treatment success was 74% versus 45% in the drug group, with a significant difference. Patients in ablation arm also reported a significantly greater improvement in the quality of life. So this trial proved that rhythm control is not only safe but also superior to the initial therapy, and delaying ablation subjects the patient to the period of inferior arrhythmia control, leading to further adverse atrial remodeling, which will complicate their life further in the future. The technical advancement, the ablation, has given us a superior technology and an edge over the rate control. The landmark trial showed in 37 Castle AF landmark trial showed 47% reduction in all-cause mortality and 38% reduction in composite endpoint of AF HF hospitalization with ablation in heart failure with reduced AF. Likewise, in ATTAC and CAM-HF trials also, there was a significant 70% versus 34% reduction in ATTAC trial, and in CAM-HF, studies showed heart failure with reduced EF patients. Catheter ablation was significantly associated with the improved LV ejection fraction. That is the most important predictor of survival in the future. And there was reduced BNP levels compared to the medical rate control, providing the mechanistic link to improve outcome seen in the larger trials. So, in the vulnerable heart failure with the reduced ejection fraction population, AFib is not a bystander. In fact, it is a driver of mortality. So, it has to be controlled nicely. Rate control is a palliative measure, whereas rhythm control by ablation is life-saving measure, and it preserves the remodeling. In fact, while the primary intention to treat analysis in Cabana shows that a massive crossover, but the quality of life in Cabana trial demonstrated a profound and sustained improvement in quality of life score with ablation that was vastly superior to the drug. Disease progression with ablation was significantly more effective, and it prevents the progression of paroxysmal AF to persistent AF, directly intervening into the natural history of the disease. So, what is the mechanism? How this
Dr.
the
Tripathi,
rhythm control?
concluding slide, please.
So, I thought I have to speak both. So, I have both.
No. So the time is limited.
Okay, great.
Thank you.
So, I will be summarizing just in now. Call for attention. A new clinical algorithms should we advocate that the patients who have AF recently should go for a ablation rather than patients who are older and have AF persistent for a more longer period of time should go for a rate control. So I conclude my debate between rhythm and rate control to continue cite the AFM trial as a justification for the rate control for strategy to ignore 20 years of it ignores 20 years of the scientific progression. Data is unequivocal. Early in the course of the disease, and the rhythm control should be executed with the modern tools like the catheter ablation. Rhythm control strategy is superior in reducing cardiovascular events, particularly in vulnerable population like heart failure. And question is no longer if we should pursue rhythm control, but now how early and how effectively we should implement it. It is time for a clinical guidelines or in our daily practice to reflect it in incontrovertible and new reality. Thank you.
Thank you, Dr. Tripathi, for very nice overview. And I think you have on the rhythm control. There are also quite good, robust, pharmacotherapy has also come, and so the early recognition and early treatment is the name of the game. If you treat it early, whether it is with the pharmacotherapy or ablation, then I think the things will be much better in long term. So we should strive to control the rhythm. So let the patient be in sinus rhythm to decrease the adverse events. Yeah, doctor.
Ani, I just wanted to say that, of course, a wonderful presentation. I think it is now undoubtedly accepted that rhythm control is better than rate control. But sadly, the reality is that most of our patients present when they have well-established atrial fibrillation in late stages with a lot of remodeling of the atrium and so on. So it becomes unavoidable to just go for rate control rather than rhythm control. But yes, and the other, of course, problem is the paucity of centers where ablation therapy is available and the expense involved. But yes, in an ideal world,
So you are right. Basically, we have to identify it early, control it early before it progresses into the changes in the atrium. The slide I skipped was the data was based on the MRI outcomes in stage 1 and 2. If we try, it's a wonderful result. But if patients progress into stage 3 and stage 4 MRI classification, then the rhythm control becomes poor in those cases. So the more and more cases we detect, more people will come forward and do the radiofrequency ablation, and more radiofrequency ablation will be available. And we have masters to teach us, like Dr. Viveka will teach us how to do it.
we all agree with that. Thank you so much.
Thank you.
Yeah, so I think the other downside was that, for ablation arm, you need more than one procedure, which is more acceptable in Western world where the affordability is not an issue. So to keep the patient in rhythm control, in sinus rhythm, you need to be more, you need to take more pain as a doctor also and the patient also, because they'll have multiple interventions, ablation, then the pharmacotherapy and regular control, whether he is slipped into AF, and also whereas the rate control, as Dr. Tandon said, it's very easy. You just put the pharmacotherapy, AV nodal conduction things, but the data clearly shows that those who are rate control, they do inferior than the rhythm control in all the heart failure to even preserved ejection fraction group as well. So
You
thank
are
you very
right.
much for your kind
Yeah, you are right, sir. Because in the first time only, it's a 65 to 70% likelihood that patient will remain in the rhythm control. But if we do the repeat procedure, it's 35 to 90% likelihood that patient will remain in the sinus rhythm.
Excellent. So give a big hand to Dr. Tripathi and